Good afternoon, everyone. Welcome to session 17, track 1. This afternoon, we're going to have a live case transmission from National Heart Center on complex PCI in a chronic kidney disease patient. My name is Aaron Wong, and my co-chair, Dr. Kwan Lee from University of Arizona from US. And we have a panel of distinguished doctors and experts in interventional cardiology. I just going to very briefly introduce them before we go live because we have a very short 50 minutes live transmission. Dr. Katie Chan from Hong Kong, Dr. Fazila Malik from Bangladesh, Dr. Al Fazir Omar from Malaysia, Dr. Fuminobu Yoshimachi from Japan, and Dr. Goh Yoseong from Singapore, Changi General Hospital. And the chat moderator is Dr. Qing Chi Yang. So I think without further ado, we will just go straight to Heart Center Cath Lab for the case presentation.
Hi, Aaron, can you see us?
Hi, Jack. We can hear you very well.
Hi, Aaron. Yeah, you can see us now, right? So I just want to introduce my co-operator. My name is Jack. This is Dr. Liew from Changi, also from Singapore. Dr. Kim is our fellow graduating soon from Myanmar.
Hi.
And our scrub nurse is Dr. Miss Tina Teo. Please zoom in on the face big, huh? So we recognize all the efforts of the team here. We can't show you our technicians, but we jump straight to the case. Boon is going to tell us about this somewhat common case that we face in clinical practice, very challenging in some ways. Boon, please.
Okay, so we have a 53-year-old gentleman with the CAD risk factors of hypertension, dyslipidemia, and diabetes mellitus. He's got a history of smoking and a significant past history actually of metastatic renal cell carcinoma with nephrectomy done. He's got chronic kidney disease stage coming to stage 5, and his latest eGFR actually is 12. He presented to cardiology with atypical chest pain symptoms in April 2020, and transthoracic echo then showed ejection fraction of 45% with wall motion abnormalities. He subsequently underwent a myocardial perfusion imaging, which actually showed severe ischemia in the LAD territory, and underwent a diagnostic coronary angiogram in December 2020, which showed diffuse mid-LAD disease. This diagnostic coronary angiogram procedure was actually complicated by contrast-induced nephropathy. So his 12-lead ECG was otherwise unremarkable. He was in sinus rhythm, and there are no significant ischemic changes. Of note, his hemoglobin is low. His HB is 8.6 and has dropped to 7.8 with no bleeding symptoms. His latest eGFR, as mentioned, was about 12. And otherwise, the diabetes was actually well controlled with a HbA1c of 6%. His Euro score was 1.3% with a syntax of 35.5. And Mayran score was 14% for CIN risk with a 0.12% of risk of renal replacement. Actually, he also has got this allergy that was documented to iohexol previously. So I'll leave it to Jack to take us through what we have done so far.
So in summary, we have a youngish gentleman, CKD stage 5, diabetic with severe ischemia, and then documented to have a tight LD lesion concurring with the MIBI scan. The complications are the fact that he has contrast allergy with eGFR of less than 12. So I think this is a good case to discuss with high bleeding risk features as well. Aaron,
okay,
back to you.
Jack. Yes. So can you just play back the PowerPoint, because I don't think you're going to inject any contrast, so we have to let everybody on the panel and the audience to have a look at the lesions in the LAD, because it was very fast that you go through the slides.
Yeah. I'm sorry, Aaron. So we go back to the areocranial view. It's a single vessel disease, and as what Boon said, after the cath, which used about 50 mils of contrast, he went to AKI and had to be admitted for quite long. So maybe you can have a look at the areocranial view on the PowerPoint.
Yes, we can see it, Jack. Yeah. Yes, we can see it, Jack. Yeah, so actually it's a very long diffuse disease, and there are two diagonal, quite big diagonal branches coming out, which may complicate the things a little bit. Yes, so I hope you guys have a quick look, because we may not have a chance to have a look at the arteries again. Kwan, just ask some opinion from panel before we let Jack tell us what he's planning to do. What would you be your strategy? I think the lesions may not be difficult, but because of the contrast volume problem. So what would be your strategy in US? Yeah.
Yeah, so you know, obviously we're gonna stick to all the basic good housekeeping rules for to avoid CIN. You know, we rehydrate the patients, etc. Avoid nephrotoxic drugs. Correct anemia if we have to. Most patients who are CKD patients are also HBR patients, so you have to pay attention to all those things. Make sure all your drugs are dosed appropriately if you're going to be using drugs that are affected by renal function. In this setting, clearly a very, very low contrast strategy would be good. You know, there's some data that suggests that radial approach is superior to femoral approach. We tend to use a smaller size guide. So if I can get away with it, I actually drop down to a 5 French guide. And then, you know, obviously a heavy use of IVUS and IFR, especially with co-registration, would be very helpful. You know, so what we would probably plan to do is wire that LAD down with an IFR wire, maybe, and then I see you have a biplane room also already set up that we will obviously, if you have biplane available to use, do a biplane, perform an IFR with co-registration so you understand exactly how long it is you have to stand. We would then wire the diagonal or one of the diagonals to serve as an additional marker so you don't have to use more contrast, and then run an IVUS, get all your anatomical sizing down correctly, and then stand away, you know. I think that's the thing. Let's ask some input from around the world as well. Maybe we start with Dr. Malik from Bangladesh. Any other thoughts?
Well, that was a brilliant summary of what needs to be done, and I think we really don't need to add anything much. But here, obviously, the concern is that this is a very long and diffuse lesion. So from where to start stenting and where to stop, that would be properly evaluated, obviously, if we do an IVUS and, as you've said, IFR. So I look forward to seeing what they have done. And great summary, Dr. Lee.
Yes, Jack. The question about doing radial versus femoral. So in your case, which approach did you use and the reason why?
So his creatinine is close to 400. His eGFR is less than 15. The surgeons are prepping out for the left arteriovenous fistula actually on the radial artery. So I think I really want to conserve and not have the radial artery thrombose off, which is around 5% risk, and it's a lifeline for him. So I opted to go femoral, noting that this chap is above 100 kilograms. I have a PowerPoint showing I use an ultrasound guided puncture in this case just now, so that I can close the groin after the procedure as well without shooting further dye. So the strategy is as simple as what Kwan said, but as difficult as what Kwan said, which is to minimize the contrast use. We are aiming to use less than 12 mils of contrast for this case. And because of the high bleeding risk consideration, IVUS guided procedure is crucial here to really optimize our outcomes, and therefore potentially we never know when this patient will have a depth interruption, noting that his HB fluctuates between 8.6 to 7 plus. And we don't have an overt source now, but he can bleed anytime. And I think stent optimization is really crucial here. So our strategy is to keep it simple, not make it complex, treat the main culprit vessel, which is LAD, optimize it with IVUS, and then end with a case with less than 12 mils of contrast. So that is the plan so far, yeah.
Dr. P. Chan, do you have any input? What the people in Hong Kong would do in this case?
Well, I think basically Kwan and Priscilla and Jack had mentioned most of the important points. Of course, tend to use minimal amount of contrast, try to reduce it to a simple procedures. But it all depends on the complexity of the lesion, because many of these patients have chronic renal failure, the vessel may be extremely calcified. So the imaging may tell us a lot on deciding our strategy. For some tips and tricks, all right, we still need to try our very best to prevent complication. For example, these sort of cases, try not to use hydrophilic guide wire. If someone paid particular attention to the end of the guide wire, because sometimes we are forced to use more contrast if there's perforation. We cannot diagnose guide wire perforations by the imaging. So very important to pay some particular attention to this fine details of the procedure. Try to make it simple, safe, without complication, minimal contrast. I think that will give the patient the best outcome. Of course, the imaging that people mention is for the pre and the post management of these optimized stent result. I think these are the most important points.
Yes, I think it's very important that during the wiring, make sure that the wire, during the procedures, make sure that the wire is not covered too far or in an abnormal position, because once you have complication, you have to use dye to make sure that there is no, to identify the complications. Yeah. So also have to be very watchful on the ECG as well, and also patient symptoms, because if you have no reflow, you get ST elevation, patient got symptoms, and at that time you have no choice. You probably need to use some dye to identify the problem. So Jack, can you just let us know what you have done? Yeah.
Yeah. So I just want to share with the audience exactly how we go about sharing our tips and tricks of doing minimal contrast here. So here is ultrasound guided femoral puncture. It's a EBU 356.
Yeah. Okay.
Can you toggle to the next screen, please? To the live cath lab.
Yeah, we can see the ultrasound.
Okay. Yeah. Okay. Good. So it's an EBU 35 guider.
Excuse me, Jack.
Yes.
This is Yoshimachi speaking from Japan.
Yep.
Hello.
Yes. Go ahead. Go ahead.
Yeah. Go ahead.
May I speak?
Go ahead.
So, Jack, this is Yoshimachi speaking from Japan, Slender Club. Hi.
Yes.
So,
yeah. Hi.
In this
nice
opinion,
to see you again.
hi. Yeah. So, in this opinion, we Slender Club perform the distal radial approach. Why don't you perform distal radial approach? Of course, I understand the femoral approach is the standard, but in this situation, we can.
That's a good point from Prof. Yoshimachi. So, but I stick with what I'm familiar with. I have tried a few distal radial. I'm not yet comfortable that I get success 100% of the time. I'm more comfortable with femoral puncture and closure device. So I'm sticking with him. But I think it's a good alternative to consider as well. Yeah. So I'll just move on, Aaron, if I may. So I use a EBU 356 French engaged without shooting any dye. Then I don't like the feel of just the FFR wire. Actually, my strategy is show the intrasite system to mark out the length and potentially where the greatest drop is to see where I can simplify the procedure. So I use a run-through wire, a non-hydrophilic wire, to get into what I think is the LAD. And you can see that it traverses quite well on the workhorse wire first. Then using this as a landmark, which what I think is the LED, this is the IFR wire going in. This volcano IFR wire system. And this is the IFR wire transversing to the distal part of the artery. So I'm going to show the intrasite co-registration for IFR pullback. And as you know, for the co-registration, I do need one shot in one plane to co-register the IFR pullback. So this is with 5 mils of contrast. Last system is quite big. So we needed to use up to 5 mils of contrast so far. Using the next tip is to use a 5 mil syringe to do the injection. And this is a hand injected system. Because it's allergy, we switch to Visipate. But this is the first shot and only shot that we might have for the procedure. So the angiogram shows the tight mid-LAD and tight also we think angiographically distal segment. So OB-Van, can you switch to the intrasite? So this is a pullback, slow pullback on 15 frames on the IFR wire. And at the spot IFR, actually distally is 0.31. So we know a severe ischemia. The value of the intrasite is to see whether there's opportunity to identify a segment for the greatest pressure drop that we can concentrate our maximum effort and stenting on. So not surprisingly, the mid segment is very tight. But can you show the next view for the pressure decline? Yep. So Aaron, I'm not sure whether you can see this marking. So for those who are not familiar with this SingVision intrasite, this is pulling back on the IFR wire. You can see those dot markers. Those are IFR value drops across the lesion. So the machine tells me that the greatest drop is a mid lesion and a distal lesion, but it doesn't quite mark out those lesions at the second diagonal. So my strategy then was to say that, yes, this is not too bad a shot. I could use this to gauge the length of the lesion, but I'm going to use IVUS anyway. So I proceeded to do IVUS for this patient. Can you go back to fluoroscopy?
Yeah, so can I just pause here for a little bit?
Yes.
Sorry, go ahead.
Jack, that was a pretty interesting IFR finding. You would have expected there to have been more of a gradient across that second diagonal area, but instead we see very, very focal disease at those 2 points. Unfortunately, the question then, do you really believe it, and can you just stent across where the 3 bars are the brightest? Because when you IVUS it, clearly the disease is going to extend downstream. Or do you need to ignore it and just go ahead and do it? Because you probably do not want to repeat the IFR again, because the literature about whether this is accurate in predicting how well the IFR improves afterwards is not 100% tight. Even though this picture suggested that for the most part it works, it's a very strikingly, surprising finding that we're seeing here.
Yeah,
yeah, it surprised me as well, and I can't explain it.
Yeah, so Dr. Omar, from this sort of IFR finding, would you stem from the first septal down to the second diagonal, or you would just believe the IFR just to cover the that 3 longest bar?
Yeah, thanks, Aaron, and thanks, Jack, for giving us a very beautiful case. I think what we discussed with Jack before getting CKD, and we find that CKD, yes, there's one challenge here is to optimize the stent, but the second challenge also is to make sure that it remains patent for a long time, and that's the biggest challenge we have for CKD patients. We don't use, I've not used that much IFR here in Malaysia, but I would definitely correlate the findings with IVUS. But if I don't have an IFR, I would definitely go up to the second diagonal. And I like what Kwan said about using the wire as my landmark as well, so that I might put a wire. We're not so familiar with IVUS and minimal contrast, so I might put a wire in the septal branch later on, so that it will help me, assist me to place my stent in this minimally contrast strategy.
Yeah, I think even if you believe the IFR, to land a stent at the middle between the diagonal 1 and diagonal 2, it may cause it, because it's a disease segment, so it may cause dissection as well. So it may not be a good landing zone. So for me, I would probably, like Dr. Omar, just from send right down to the diagonal, second diagonal. So Jack?
Yeah, so can OB-Van switch back to fluoroscopy, please? Frontal view. Live fluoroscopy. Yeah, thank you very much. So I also like the idea of getting a second marker wire to minimize contrast. So we put a second wire into the diagonal 2 because I felt that I needed to mark the distal segment more for the timing rather than the first septal. I didn't want to push and cause a lot of issues transversing, and I decided ahead of time I'm just going to stent the whole segment actually past the second diagonal. So I pre-dilated the segment with a non-compliant 2O balloon and did an IVUS run. Before I show you the IVUS was really good because it allowed me to mark out the points, the size, and the length of the whole disease segment of where I want to stent it to and mark it on fluoroscopy. So you can see that this is where I think the distal normal segment based on the IVUS imaging is. And this is where the proximal landing zone to the normal segment occurs. Distally is about 3.0 to 3.5 vessel actually, surprisingly. Proximal is 4.0 to 4.5, and the left main is 6.0 vessel. So it's a huge vessel that was demonstrated on the IVUS. So before I show you the IVUS also, just to save some time, we went in based on the IVUS finding post-tour balloon. We were not happy with the result. We went in with a 3O. This is a 3O Wolverine cutting balloon, dilating across a calcified segment at the D2, moving backwards all the way to the culprit segment before repeat IVUS. So I'd like to show you now the IVUS post-cutting balloon. So do you have, this is segment, okay, let's play the post-cutting balloon. So this is pulling back or with automatic pullback from distal LAD. So maybe then you guys can comment.
So you can see that the distal LAD actually is a fairly big size vessel. It's about 3.0. And coming back, the vessel gets bigger to a 3.5. And so later we will explain the rationale for the choice of stents. And I think what surprised us was on IVUS, we actually saw a segment just proximal to the D2 that was actually heavily calcified, which we did not anticipate based on angiography.
So this is a D2 wire coming in on the IVUS. So this is a segment that had initially a 2O balloon couldn't fully expand. It's actually quite calcified. Surprisingly, on angiographic finding, we couldn't quite appreciate this segment of heavy calcification.
Yep. But it did
but
expand well
with the cutting balloon, we can. Yeah, and we can see cracks in the calcium as well. So we're quite comfortable that the lesion is prepped enough. I wonder whether anyone has any other opinion later.
Just a comment, Jack. So you had a second wire in the diagonal to mark the position of your lesion, and a cutting balloon was used. I just want to know, is there any concern when we use a cutting balloon and we have a second wire in the blood vessel?
Yes, there's a theoretical concern that you can shear the wire off. I have done quite a few times this maneuver. I'm not being able to cut off my wire. I think the cutting blades need to be really aligned to it. There is a risk, so Boon was asking me, do I really want to use a cutting balloon? But I chose some form of scoring a cutting balloon because I needed a bit more controlled dilatation for a larger balloon rather than NC. Because if it dissects and you got ST segment changes, I have to shoot and then use more contrast. So I wanted a scoring type balloon instead.
Yeah, I think that's a good rationale for using the cutting balloon. But I think because the vessel is elastic, so if it's not calcified lesion, I think it's safe to use a cutting balloon with the wire inside. But if it's very severely calcified, then if the balloon cannot expand the artery, it may theoretically cut off the shear of the wire.
So OB-Van, can you switch off to the angio now? So I just like to explain my strategy, then move on to show you what we've done. So we did mark out the distal reference is about 3.0 to 3.25, and then it extends all the way to before the second diagonal, and my marker wire is in the third diagonal, so to speak. And then you have a length of about 36.5 to 38 mm. Then pulling back all the way to a proximal normal segment up to about 4.5 diameter is an extra 29 millimeter of stent length. So we decided to go with Zines 3538 to cover that segment. So we had the marking, and this is a Zine stance in this position. So you can see the diagonal 2 wire marking out, and then we have a previous safe sequence of where the IVUS catheter is, and this is where we felt is will cover across and not jailing either diagonal. So we went up here at very normal pressure. Before that, the purpose of the D2 wire was as a marker wire. So we drew the D2 wire because we didn't want to trap it. Then on pulling, you may have wire issues or guide issues. Remember, our purpose is to keep it safe and watch out for all these other complications. At 8 hemispheres post-dilated nominal, we did another IVUS. The result didn't look quite as good, so we post-dilated with 3.5 NC balloon. Then we repeated the IVUS. So you can see, Kwan, the other thing is that rather than try to test, we did multiple IVUS runs. We watched the pressure and the ECG. There were no changes. We saw some flaps in the mid-LED segment that were concerning because there's some dissection there post balloon Liew. Now we're happier actually with this result. And using the IVUS, we could mark out exactly the stent length from overlap segment in the stent back to the proximal LED segment. So we don't need any more marker wire in the septal. This length we measured to 32 millimeters actually. So we are at this stage now, we are about to implant the second overlapping stent, optimize it, repeat the IVUS run, and maybe if you have time, do a IFR pullback again to demonstrate the findings. And the last note is that we may want to follow the Poseidon protocol, which our department may be adopting, to look at the LVDP to decide on the fluid hydration regime. So this is what we have. Maybe we have another half an hour or so. I want to go ahead and plant the stents, and maybe the panel can have a discussion around the topic as well. So I'm going to go ahead and place the stents if there's any questions.
Yeah, sure. Jack, the wire that you use for the side branch actually is a feeder. It's my workhorse wire, but this is a hydrophilic wire, so you have to be a bit careful when you do this minimal contrast, because this hydrophilic wire may exit the artery. Yeah.
Okay.
Yeah, Jack, when you estimated the length on the IVUS, did you use a pullback sled, or is that?
No, we use a manual, so we reset it to 0. Then we use a manual pullback.
Manual pullback.
We have the sled. We have the sled.
Yeah, the Philips.
We use the sled to mark.
Right. The Philips system also allows you to estimate the length on the IFR pullback tracing. You can actually grab the thing and come. I'm just wondering how close the two things came together, because that would be another way of estimating length, besides also just using long balloons, or on the volcano. IVUS, you have markers, and sometimes you can use those. But the volcano IVUS obviously is the image quality is less is inferior compared to the the Boston rotational.
So previously we marked we can't really get a good, we'll cone in a little bit. We didn't want to move the eye because it's co-registered. So we are a bit caught here. I'm just going to do a plain cine, no stem boost, because we can't cone in. Okay, ready?
Come back maybe one structure. Yeah,
okay, this is actually okay. No?
This is okay.
Okay, let's go up here.
Yes.
Stand deploy.
Yeah, it looks like it's overlap.
12.
13. 14.
But Jack, do you really need to use a correg again? Because you're not going to use a correg system anymore, right? So you can move the II.
No, so I'm thinking whether I want to do a final IFR pullback with co-registration, just to show that if there's any drop, I can figure out where is the drop, you see. Can I have the post-Liew balloon? 4-0.
4-0.
But I agree with you, Aaron, it's probably not crucial. But since I only have one shot, I didn't want to lose a co-registration plane. So I will move from that position, actually.
Yeah, so one of the ways that
and then show you guys IVUS.
Yeah, one of the ways actually, sorry, I'm just saying that one of the ways to mark out the position of the, for stent placement and to know where the arteries is usually to use the multiple wire to put in side branches. They call it the metallic silhouette, so that you can identify where the side branches are. But that will require a bigger guide. Yeah, so that's why I'm going to just ask about the guide. Kwan mentioned that using smaller guide. I think using smaller guide, you can use a smaller volume of contrast. Yeah, but it may impede on sort of this technique of using multiple wires, or sometimes using IVUS to guide the stent placement.
And also, with the calcification that was encountered in this case, clearly if you started off with a 5 branch, you would have trouble if you had to switch up to rotablation or something like that.
Yeah, correct. Yeah. So they actually, one of the paper published from a Polish interventionist actually said that using 7 branches better for this minimal contrast. But I think that some French, because the guider itself has contained a lot of contrast, so it's very difficult to if you need to do an injection, then you have a lot of contrast coming out.
Some people even advocate as one is that you actually aspirate from the guide to pull back any additional contrast, so no contrast goes forward. But
Yes.
you know that requires a lot of being very deliberate and a lot of effort.
Yeah, so we did that for this patient actually. After the first shot, we aspirated whatever contrast was in the tubing. So we know strictly we have just used 5 mils of contrast so far. Yeah. So we're going to go in with IVUS now to show you the results. We think that the proximal stent edge might need a 4-5 balloon to optimize it further, but we'll have a look first.
So can I just ask, you know, the patient who has CKDs, I find that the discrepancy between the visual and IVUS is always a lot bigger because there's such a huge plug burden. Do you find it the same as well? Like you find the vessel quite small, but when you do IVUS, it's actually a very large vessel. It's more so compared to all the other clinicals.
Yeah, definitely I agree with you.
It's okay, no need to be 8 because it's not polar. So then,
Dr. Yoshimachi, do you have using this zero contrast or minimal contrast PCI in CKD patients?
Yes, of course, yes. So actually, we sometimes perform this type of the intervention with using the 5 French guiding catheter via distal radial approach. Of course, multiple guide wire insert to the diagonal or the septal branch is very useful. And using 5 French guiding catheter, 2 or 3 guiding wire and IVUS is available. If we want to developing devices, we can use OAS. It's very effective with 5 French guiding catheters and getting big lumen. So maybe we perform 5 French guiding catheter. It's okay.
Yeah.
But actually, you always use the 6 French guiding catheter in daily intervention. 6 French guiding catheter is the best guiding catheter for in this case.
You know, OCT is much better to assess the calcium thickness and the distribution when compared to that IVUS. Any people or any expert in the panel will consider using OCT, of course, contrast-free OCT. Dr. Yoshida, will you use OCT without any contrast? Use saline or use lactate and all these stuff?
We've used dextran here once or twice. You know, it's hard for us to get. It's not readily available. We find that with saline on the right coronary artery, you get fairly good pictures, but on the LAD side, it's quite hard to get good pictures with the OCT. Yeah, I mean, those are great points.
I think there was some report that dextran can cause us renal impairment as well.
Yeah, and large quantities of dextran can cause renal impairment, and then there's anaphylaxis to dextran, and sometimes it can also be procoagulable. So if you end up using a lot of dextran, that might be an issue. So it's not a free pass to just keep using it.
And his ejection fraction is also not that good, so we don't really want to give him a lot of volume as well.
Can we go manual?
Yeah.
Manual.
In the United States, you know, there is some data that suggests that impeller use in low EF patients, less than 35% with CKD, actually, decreases the rate of AKI. That's not in a very large trial, but you know, it's a very expensive way to avoid AKI, because this patient is not hemodynamically unstable. There's a question from the audience.
12, okay.
Somebody asked, can BEBs be used in cases requiring minimal contrast PCI? We don't have BEBs United States. Anyone on the panel?
Yu Xiong, you want to comment on that?
Yeah, I think using a DEB will be a bit risky here because, as you know, DEB will cause dissections and lesion preparation can be done properly. So, and we can't give any contrast. So, kind of hard to see whether or not
So
there's
after this,
any
give me
spiral
the
dissection.
IFR wire.
On IVUS, yes, you might be able to see some flap, but you're still a bit worried for you move the wire if you don't use any contrast. So I'll hesitate using DEB for minimal contrast PCI.
Okay, I totally agree with that because you can't tell whether there is a dissection. So Jack, there is one question which is quite reasonable, I think. Say patients being prepared for dialysis anyway. So is there any additional benefit for minimizing the contrast in this case?
Okay, down. So we always try to delay the events of dialysis, and it's not just the dialysis requirement. He's not 100% for dialysis now. The IVL is not prepared. Plus, he has contrast allergy. Although we switched to visor peg, it's still a bit worrisome to put someone to too much contrast if they have allergy. So for this point, I think it's still better to go minimal contrast. Let's go up here.
Yeah, sometimes we see people having fistula for months or even years, you know, before they go for dialysis. Yeah. So if we could delay as long as possible, that will be good, good for the patient.
Stem boost again.
Jack, sorry. This nagging question about my mind. When you do your first angio, you use VisiPig as well, right? Any issues with that? Any allergic reaction? Any debilitating?
No, he mainly went to AKI, but not directly an allergic reaction. He was prepared for it though, with oral prep going into the procedure. For this procedure, although we're minimizing the contrast, we still gave him some IV hydrocortisone pre-procedure. So the IFR wire.
Yeah. The other question from the audience is quite good. Is this question about in CKD patients that calcification is really common, and they're asking about questions about rotobladers, orbital atherectomy, IVL therapy in CKD cases. I suppose theoretically, given how much less contrast you are trying to use, you probably prefer, if you can help it, to use IVL versus rotoblader or OS, just because of the slightly higher risk of perforation with the other modalities. And if you ever get perforation, then you have no choice, but you're going to have to bail yourself out big time. And there'll end up being a lot of contrast used under those circumstances. Any thoughts from the audience? Dr. Malik?
But actually, I think, you know, one of the things that you notice in a CKD patient is the calcium tends to be pretty diffuse in nature. So with the diffuse calcium, I think a rotablator would be, and the vessel calibers usually, not in this case, but in many instances in CKD patients, the vessel caliber is also not that great, and the lesions are quite different. So with that, I think rotablator can be a viable option because you can, you know, choose your own burst size. And if it's a diffuse lesion, shockwave might be a challenge.
Yep. So, and then that's where the imaging comes in to help you plan and gives you those options.
Yeah.
So when it comes to CKD patients, I think I like what Alfaze said. Actually, I think the first priority is to make sure that we have a good, safe, and durable results. So I think when it comes to getting the best result, sometimes you might have to compromise on the contrast use. I still wouldn't shy away with whatever needs to be done just based on the lesion type. If you need to attractomize, just attractomize. If you need to do some more aggressive lesion prep, just do that. So let's do so this is an IFR wire going in. I'm going to just show the panel how the spot IFR is like post-stenting without any contrast so far. So we're running. Can we switch on to the spot IFR? It's still low. Now we're going to do IFR pullback run. Then we can have some comments. So we're going to go live. I'm going to step on the floor. Can you switch to 15 frames? I'm not too sure whether the correlation will still work, but we're going to try. So fluoro first. Oh, we can't see it at the moment.
Because I think the patient is...
The patient has moved a little bit. So we see where is he now, okay? So we try. So IFR pullback. It's been a fairly long procedure. So this is pulling back now. We pull back slowly. Then we see where you can see any appreciable IFR drop.
So at this point, there's quite a bit of drift already. 1.06. You're not even at that.
Yeah, yeah. So let's off. I'm going to stop, then off the fluoro. Then see whether it's able to show any. Let's see whether it's a drift now. Can you co-register? Is it still possible? Let's check whether my initial shot correlation is a single shot. Yep.
Jack, is that the Verata Plus or is that the new wire?
Verata Plus. I believe it's a new wire. It's a Verata. It's the Verata.
Okay, it's the old wire.
Plus. The new wire is better, is it?
Yeah, the new wire is supposed to be better because it's not. It's you know, the old wire
has
a hollow core
live and
to
see
it.
whether there's a drift. Actually, Quan, there's no drift, you know. I don't see any drift. This live. I'm sorry, I think the patient in between has moved, so I couldn't do any co-registration. You saw the final IFR, and any thoughts on that?
There seemed to be a lot of step up distally, you know, distal to the stent because you started close to the apex and you came back, and once you entered the stent, it looked like it was coming back to normal, but
adenosine, please.
It's hard to tell.
Yeah, I think I would trust my IVUS final result, which looks decent. Let's move the eye. Show me the wire. I think
the IVUS look perfect.
Let's move up. Show me. Move the table.
Move the table.
Move the table. Show me the wire.
Yes, that's good.
Okay, let's give me some adenosine. Let's see the 200 adenosine IV.
200.
So can I just ask, we have this final IVUS before I post-dilated the proximal with 4.5. It looks fairly decent to me. I'm going to do a final IVUS run. Would the panel still do a final cine run with contrast?
200.
Yeah.
Well, I think you still have 7 mils contrast to play around with.
I think, yeah, from the literature, people do it for medical legal purposes.
Okay, ready? Go.
Because there's no way to document that you have done a good job. And if you need to go for another intervention, the previous, the person won't know what the previous angio looks like. But I think if it's extra 3-5 mils, I mean, Jack still have about 7 mils to go, I think, yeah.
Yeah, I think I have some concerns.
Yeah, I think also because a lot of the change is distal to the edge of the stent, there might be a distal stent edge dissection. The IVUS didn't show it, but you know, a lot of what's happening seems to be this downstream to the stent, which I'm not sure we IVUS that deep down. You know?
Yep,
especially if
also my final IFR and FFR is both concordantly positive with no drift. So I think it's good to have a look on the cine first before you decide on the final IVUS now. So everyone will agree we use the remaining contrast here.
Yeah. Sure. Well, especially sometimes you got an expected distal guide wire perforation, then we change all the management plan. We got cases that a couple of hours later, the patient developed hemopericardium in the CCU. Then you need to bring the patient back and then find out that there's a very distal side branch perforation by the guide wire, of course, inadvertently. So I think it's important to document that. I tend to agree with Aaron.
Yeah, one of the recommendations for low volume contrast work is to do an echo immediately after the procedure, and then once or twice again soon after, just because, you know, just in case you miss some perforation.
Sure.
So we try to keep it to 5 mils again. We see that diagonal 1 and 2 are patent. The results looks decent. I don't see any flow obstructive lesion distal to the stent. I don't see it on the IVUS as well. I mean, we're just using 5 mils of contrast in a large vessel. I don't see obvious perforation. I'm actually quite happy with this result, if you ask me.
Yeah, it's a great hydrographic result, and the degree of relief of ischemia that you achieve from 0.35, you know, IFR to 0.85 is massive, right? I don't think
0.31.
0.31, yeah, 0.31 to 0.85 or whatever it was. I'm not sure what you're going to be gaining from chasing this further. The patient is a lot better. And we all know that in the FFR post-PCI literature, the outcomes are proportionally related to how severe the residual ischemia is as well. So having taken it from 0.35 to 0.85, there's been a huge clinical gain as it is. It's not a dichotomous thing. It's the severity of ischemia predicts outcome.
Yeah,
so actually, I'm
think,
quite happy with the result.
Yes, the IVUS looks good, and geographically looks pretty good as well. So that's why if I do FFR, I usually don't do it after the procedures because it always gives you some some not very satisfactory results.
You suck back, right?
Yes,
Yeah. So
we
Jack,
also suck back the remainder contrast. We suck back the remainder contrast in the line. I think I'm going to stop here. Boon may want to talk about the Poseidon trial protocol that we are thinking of, whether anyone adopts that protocol for hydration. Boon?
So I think in this case, we feel that maybe adopting the Poseidon trial protocol will be useful because his ejection fraction is impaired and he's also got advanced CKD. So more objective guide to fluid management, I think will be ideal in this case. So we are going to put in a pigtail catheter. Yep.
Yeah, there was also the remedial tree trial that was published just recently last year from Italy, where they compared the two strategies, the LVEDP guided strategy versus just diuretic plus matching fluid, infusion to urine output. And the second strategy actually ended up being better than the LVEDP strategy. So, I think both are valid. We're approaching 1 minute, and I think I'm being asked to summarize at this point. So, Jack, I want to congratulate you and your team on a phenomenal case that was very elegantly performed. It was a fantastic case, and clearly, it looks like your final contrast exposure was 10 cc's in this patient who's on the brink of being on dialysis. As we all know as interventionists, CKD and post-procedure AKI is not a good thing for us to have. It's very common, and it's associated with much worse outcomes. Today we saw a demonstration of some of the strategies that have been employed to decrease the risk of CIN. Some of them are pretty straightforward, prehydrating a patient, preparing them well, using biplane, using smaller guides, as well as the more advanced techniques of zero contrast by using IFR, co-registration physiology, IVUS. We also heard about the options of using OCT with dextran. And then finally, here as you're wrapping up, we're also seeing the strategy of tailoring your hydration to the LVEDP versus the other strategy of infusing what you call it saline matching to your urine output after a diuretic dose. I think I'm being asked to stop there, so there might be a few more seconds for anybody to jump in if anyone else has something to add. Aaron, did you want to mention anything else?
No, I think it's a great session, great demonstration of to use minimal contrast PCI in this almost near dialysis patient. Yeah, so I think the time is out. So thank everyone, all the co-chairs, panelists for your very valuable contribution. Thanks, Jack, to the team. Well done.
Thank you.
Okay, thank you.
Thank you.
Bye-bye.
Thank you very much.
Bye-bye.
Bye-bye.